control the astigmatism. Dr. C. Ganesh.
Good evening, dear friends, and thank you, Dr. Madhivanan, for inviting me to this debate. So I'll be speaking for toric IOL, my choice for correcting astigmatism along with cataract surgery. Have you heard the term res ipsa laquata? The thing speaks for itself. Let us look at our patients after LRI, when they are still left with glasses because it's not an effective procedure, and they keep rubbing their eyes because of the irritation that it produces. And after toric IOL, you have the young lady smiling beautifully and very happy. So how do you want your patients after surgery? You'll have to decide. What is the best to correct astigmatism when there is cataract? Relaxing incision, toric intraocular lenses, or cataract surgery followed by LASIK, placing surgical incision. There are different options, but my option is a toric intraocular lens. If you look at the additional corneal refractive procedures like LRI, incision at steep axis, or doing a LASIK PRK, outcomes depend on multiple factors: age, depth, length of incision, attendant risk of second surgical procedure, etc., etc. So it has its drawbacks. With a toric intraocular lens, you have efficient correction of higher degrees of astigmatism with precision using a single step small incision approach without any corneal tissue manipulation. It doesn't require any new skills for the surgeon or an additional procedure. Let us look at what surgeons prefer. This was a new iWorld article, latest iWorld article, which clearly says the bottom line for me is that toric IOLs are a safer and more effective methodology for managing corneal astigmatism at the time of cataract surgery. Most of our esteemed colleagues believe in this. Let us look at what are the advantages, disadvantages. Mode of action, toric IOLs, it corrects at the IOL plane. There is no corneal tissue handling, whereas LRIs, the flattening effect depends upon localization and length of incision. Large incisions required to have a substantial effect. Most of them don't work for astigmatism over 1.5 diopters. Predictability and efficacy, toric IOLs, more precise, predictable, reliable, stable, no risk of regression. Here it's surgeon dependent, variable, unpredictable. You can get overcorrection, undercorrection, changes due to wound healing, regression. Range of astigmatism, yes, you can correct up till 11 diopters with a toric IOL, but with the corneal incisions, you can correct only 1.5 diopters. If you go closer to the visual axis, it's very irregular, very unpredictable. And calculation for a toric IOL is very simple to calculate. You have online calculators, the company calculates it. For LRIs, it is very complex and you have multiple nomograms because no nomogram works. Reversibility, yes, if there is any problem in the toric IOL, you can always reposition it in the post-op period. Whereas if you make a corneal incision wrong, you get your axis wrong, it is irreversible. Patient comfort, toric IOL patient is very comfortable, no discomfort post-operative. But with corneal incisions, you have post-op irritation, you have high risk of infection, wound healing problems. And even if there is peripheral thinning in the cornea with the toric IOL, you can still correct the astigmatism. You have PMD or if you have keratoconus, but with the corneal incisions, it's unsuitable. Side effects with toric IOLs, hardly anything. Whereas corneal incisions, you need incisions more than 120 degrees. They denervate the cornea, causing dry eye, and especially in this cataract age group, most of them already have dry eye. You're going to add to the dry eye. There's an increased chance of infection, delayed healing, wound gain, and even perforation, because you're not precise in setting your incisions. Let's look at this, just a small video of LRI and then delay. But here you can see that this is a LRI being done with a diamond blade, okay? And there is no way to know what is the thickness in the peripheral cornea. You think everything is fine. Can I have the sound? Okay, you think you have created a perfect incision, and then you put in viscoelastic and then it oozes out through. And then you again have to suture the wound, which defeats the whole purpose of doing this because you have a lot of irregularity, unpredictability. You can go there again with the IA and you can see it again leads to eschimosis. Let us look at the peer-reviewed journals. All journals, without fail, all the articles and all the peer-reviewed journals say that cataract surgery with toric IOL implantation have a much better results. Visual outcome, rotation stability is very good. Yeah. So this is one more study by Paul which showed that toric IOL was favored for higher degrees of astigmatism. Toric IOL implantation was more effective and predictable between 1 to 3 diopters of pre-existing astigmatism when compared to incisions. So even Robert Pineda says that toric IOLs reduce lifetime economic costs by reducing the need for glasses or contact lenses. My personal experience, I have done more than 600 toric IOLs the past 8 years. Rotation rate is less than 1 degree. Average residual astigmatism less than 0.5 diopters in 94% of cases. And if you look at the market, the thing speaks for itself. Overall growth of toric IOLs in the Indian market is 25 to 30% year on year from 2011. So more people are adopting to this technology. So I would like to conclude that there is no debate. Toric IOL is a clear choice for correcting astigmatism during cataract surgery. Thank you very much.